Dear colleagues, ladies and gentlemen, welcome to the PHC meeting. I'm pleased to present today new drugs for hepatitis delta infection, HDV infection. So these are my disclosures, but I have also to disclose, as I'm Algerian and French, that we have been 2 times football world champion with Mbappe and Zidane, and we won also the African Cup in Egypt in 2019. These are my disclosures. So this is the agenda for the next 10 minutes, new drugs for HDV infection. First, an introduction with a fantastic drug development for Hep C and Hep B, and then discuss the drugs for delta hepatitis, entry inhibitors, bulivertide, Epledex, then prenylation inhibitors, lonafarnib, then HBsAg, secretion inhibitors, and some take-home messages. As you know, the HDV virus is a RNA, circular RNA, with an envelope. And this virus needs the envelope of the HBV virus for its replication. So it's a defective virus that needs the Hep B envelope for its full replication. You know that Hep C drug development has been fantastic, and also HBV drug development has been impressive. We have many drugs, and patients are doing well on treatment. And with this success, we need now to take care of patients with delta hepatitis. In the world, there's around 30 million of patients with chronic hepatitis delta. It's around 5% among HBV infected population. It's heterogeneous in the world, but you can have high number of patients in South America, in Sub-Saharan Africa, in Eastern Europe. And with migration today, we have many patients every part in the world. There's a need to cure hepatitis D. Worldwide, we have 257 million people living with chronic Hep B. Around 5% have co-infection with delta. HDV might be underestimated, and we have new reports that say that we might have 60 million of infected individuals. We do not screen enough patients for delta. Delta hepatitis, as you know, increases the risk of cirrhosis, with many studies coming from Italy with Fatovic. HDV requires only small amount of HBsAg to complete viral packaging. In the past, there was no available therapy except off-label use of pegylated interferon. And since July 2020, there's the first approved drug to treat HDV available, bulivertide in Europe, Epledex. It's very important to understand the replication cycle because each step is a candidate for drug development. We have first the entry of the virus with the NTCP receptors, and we have entry inhibitors with bulivertide, Epledex. We can have also inhibitors like lonafarnib, and I think it's also important for drug development. And we have HBsAg, secretion inhibitors, REP 2139. So the virus was discovered a long time ago by Mario Rizzetto, who is with us in this session. And with a better knowledge of the viral replication, we will develop more drugs. So let's start with Epledex. It specifically binds to the sodium taurocholate polypeptide NTCP in the hepatocytes. It has a strong inhibitory potential for co-infection, and it targets hepatocytes. It has been dosed in more than 600 patients and healthy subjects. It has shown a decrease in RNA declines and improved ALT levels. The combination with PEG interferon induced synergistic effects. And 2 milligram subcutaneous 1 time a day has been approved for treatment of chronic delta infection in adult patients with compensated liver in Europe. I will show you the pivotal studies which lead to approval. The study MIR 202, it's 120 patients randomized in 4 groups with bulevirtide at different dose, 2 milligrams, 5 milligrams, 10 milligrams, in combination with tenofovir, and one arm with tenofovir alone. You know that tenofovir is not approved for delta hepatitis and has no effect on delta hepatitis. And you can see that the combination has an antiviral effect with reducing viral load and also a reduction in ALT level, a normalization of ALT. You see also on histology staining that in comparison with baseline, you have in reduction in HDV antigen delta staining after treatment. You can see now the approval study, MIR203. It's one arm with the standard of care, PEG interferon, and you have two doses of 2 milligram and 5 milligram bulevirtide in combination with pegylated interferon, and then 2 milligram bulevirtide alone. And you can see also an important antiviral efficacy, a decrease of RNA, and the combination with pegylated interferon shows synergies. You have also ALT normalization, ALT decrease, and you can see that the combination of MIR plus PEG interferon with 2 milligrams of bulevirtide exhibit an HBsAg response in around half of the patients at week 48. So a strong antiviral effects. Of course, it's not a large number of patients, and we need confirmatory of these studies by larger number of patients. You can see the extension study with 10 milligrams of bulevirtide with pegylated interferon or with tenofovir. In green with PEG interferon, in blue with tenofovir. And you can see the results. So the results, around half of the patients have undetectable HDV RNA with the combination of bulevirtide 2 milligrams plus PEG interferon. And you can see for tenofovir, 1/3 of patients have undetectable HDV RNA. You can see the individual data, which is very important, and all patients in both treatment arms achieved a more than 1 log HDV RNA decline. So there's no non-responders. It appears that this treatment has pan-genotypic efficacy, and there might not be resistance. Of course, we need more data before this conclusion. The ongoing study, the MIR204, which is a very important study, you have 4 arms, 1 arm with the standard of care pegylated interferon, and 2 arms with the combination with bulevirtide 2 milligrams, 10 milligrams, and 1 arm with 10 milligrams of bulevirtide alone. This study will be very important, and we hope to have the results next year. The MIR301 phase 3 studies that compare monotherapy of 2 milligrams of bulevirtide to 10 milligrams with different duration in the 10 milligram arm. Also, important study. So the summary for Epcludex 2 milligrams, ceftriaxone once daily, has been approved for the treatment of delta hepatitis in adult patients with compensated liver disease in Europe. For decompensated patients, the treatment is not approved and we need the data and studies. There are strong antiviral synergism of bulevirtide 2 milligrams in combination with PEG interferon. And so we have to consider the combination in patients. Bulevirtide high-dose therapy, 10 milligrams, was safe and well tolerated. Ongoing studies in delta hepatitis are very promising with MIR301 and MIR204. Let's move now to prenylation inhibitors, lonafarnib. Lonafarnib is a small molecule, first-in-class, oral prenylation inhibitor. It is well characterized through phase 3 programs. More than 2,000 patients have been dosed in oncology program by Merck. There's some side effects with gastrointestinal effects with diarrhea, vomiting, and abdominal pain, which is dose-dependent. Over 120 patients with HDV infection has been dosed across international sites. It has been designed orphan designation, FDA breakthrough designation, and EMA prime designation. You see the pivotal, the important phase 2 data. There's two lonafermin-based regimens identified for registrations. One oral combinations with lonafermin 50 milligrams BID plus ritonavir, and lonafermin 50 milligram BID plus ritonavir plus PEG interferon alpha. And you can see that there's a composite endpoint, more than 2 log decline in RNA plus normalization of transaminases. And this has been achieved in the oral combination in 29% of cases and 63% in the combination with interferon. Of course, it's small number of patients, and there's ongoing studies. We need more data with more large population. So this phase 2 program, in all oral, lonafermin boost with ritonavir, 1/3 of patients have a more than 2 log decline of viral load, and around half of patients normalize transaminases. And the composite endpoint, more than 2 log decline of RNA plus normalization of transaminase, was achieved in 1/3 of patients. The combination with pegylated interferon, 80% of patients have a more than 2 log decline in RNA, and 88% have normalization of ALT. And the combination was achieved in 63% of patients. Of course, we need more patients. It was also associated with lambda interferon. Lambda interferon has similar efficacy than pegylated interferon, but a better tolerability with less side effects. And you can see that this triple combination achieves an important viral decline and also a good tolerability, and studies are ongoing. Finally, there's a DELIVER, which is a phase 3 global worldwide study with 4 arms, one with placebo, one with the standard of care pegylated interferon, one with the oral combination, lonafermin ritonavir, and one with the combo, lonafermin ritonavir plus PEG interferon. The primary endpoint at week 48 is a combination of more than 2 log decline in viral load plus normalization of ALT. Secondary endpoint are histologic improvement of fibrosis. Summary for lonafermin: high efficacy in phase 2 studies, synergistic effect with PEG interferon, favorable tolerability with dose-limiting toxicities GI, ongoing phase 3 studies are ongoing, and it has a FDA breakthrough designation. PEG interferon lambda is in development. Finally, the last treatment, HBsAg secretion inhibitors. We have some replica treatments, and very interesting in this study published in Gastroenterology last year, you can see that half of patients achieve HBs seroconversion. So Replicor decrease HBsAg secretion, so you have less production of HBsAg antigen, and so in theory, a more important immune restorations and SBS seroconversion. It's a small study. We need complementary data to confirm this. Finally, for future drug development, we need to have robust endpoints. We need to have treatment with eradication of the virus, HDV cure, HBs seroconversion, and not only viral decline and normalization of transaminase. We have to show that we reduce microinflammation, we stop fibrosis progression. We prevent hepatocellular carcinoma, we reduce extrahepatic manifestation, and finally, as for all drug development, we need to show that we increase survival and we improve quality of life. So dear colleagues, ladies and gentlemen, to conclude, HDV, similarly to HBV, infect hepatocytes via NTCP. Previous treatment recommendation is pegylated interferon for 48 weeks, but for patients who failed interferon, patients who have bad tolerability, we have no treatment option. Bulivertide, Epludex, has been recently approved in Europe to treat chronic hepatitis delta with compensated cirrhosis. Drug in development for delta hepatitis include prenylation inhibitors and HBsAg secretion inhibitors. Thank you for attention, and we will be pleased to take all together in a roundtable all your questions. Thank you, and enjoy this meeting.